Rick Sidney, the President of the Association of Future African Neurosurgeons. Glad to have you this week. Before we start, we're going to have all presenters, attendees present themselves. So first up will be CBMJ. Please unmute and present yourself.
Hello everyone, I'm Celestin BILONG, fifth-year medical student at the Faculty of Medicine and Biomedical Sciences of the University of Yaoundé 1, Cameroon. Thank you.
Thank you, Celestin. Next up, Dr. Daniel Safari.
Hello everyone, I'm Daniel Safari. I'm a medical doctor from DRC and equally a research fellow at AFAN. Glad to be with you here this evening.
Thank you very much. Next up is Gideon Adeboyega.
Hi all, my name is Gideon and I'm a medical student in London. Nice to be here.
Next up, we'll have Olalowa Ezekiel Dada present himself.
Greetings everyone. Hi everyone, I am Olalowa Ezekiel Dada. I'm a second-year medical student from the University of Ibadan, Nigeria. I'm a member of AFAN. Glad to be here.
We're happy to have you. Next up, Crescencia Mashauri.
Hi everyone, I'm Crescencia Mashauri, a medical student in Russia, 5th year from Tanzania. I'm happy to have you.
Thank you so much. And we'll have Zolo Ivan.
Hello everyone, I'm Zolo Ivan. I'm a final year medical student from Cameroon. It's a pleasure to be here.
And last but not the least, Gwenole Defo.
Good evening everyone, I'm Gwenole Defo, a fifth-year medical student in Cameroon. I'm a member of AFAN.
Thank you very much. Celestin, you can get ready for your panel presentation. Okay, so Celestin, if you're willing, please unmute your mic and start sharing your screen, please.
I'll be presenting on stroke prevention.
Yes, please go ahead.
All right. So the objectives are enumerate risk factors of stroke, outline prevention strategies and goals, prevent stroke at an individual level, and contribute to community prevention. We'll be using this plan, and to start, we'll just say that stroke is a leading cause of severe neurologic disability in adults. It has consistently been occupying the top 5 in the causes of death worldwide. For example, about 4 years ago, it was the second. The global lifetime risk of stroke is 24.1% in people who are 25 years or older, and the global burden of stroke is still high. So there has been a decrease in, that's when all the age distributions are taken into account and computations are made. Those who are dying of stroke, it has really decreased since 1990, but it's still on the rise. Stroke is still on the rise because the absolute number of those who are being affected is still high. So the global burden of stroke is still high, despite that decrease. There's a need of a mass stroke prevention approach. Stroke prevention has 2 arms. We have primary prevention, which is done in someone who has never had a history of stroke, and secondary prevention, which is done in one who has had a history of stroke or transient ischemic attack. This is kind of a small stroke. We'll see a bit of that a while from now. Up to 80% of recurrent strokes may be prevented by addressing modifiable risk factors. So this is amazing. Again, that's why we need to know the risk factors of stroke. So just to review what is stroke before we prevent it, the family name is cerebrovascular disease. So in cerebrovascular disease, we have stroke, we have transient ischemic attack, we have cerebral venous thrombosis. This here is a textbook definition of stroke. Rapidly developing clinical signs of focal, at times global, disturbance of cerebral function, lasting for more than 24 hours or leading to death with no apparent cause other than that of vascular origin. So this is a classic definition. The essentials of diagnosis really is based on sudden onset of focal neurologic deficit. So focal because the symptoms depend on a particular area of the brain which is being injured. Then the imaging here, usually CT, to distinguish between the types of stroke. 2 main types. The most common is ischemic stroke, about 80%. So what happens in ischemic stroke is that the blood flow supplying a particular area of the brain decreases for some reason, and then the area, that corresponding area of the brain starts dying. So the death starts from inside out, starts from the center and then starts moving towards the periphery. At the center, that center is called the infarct core, this is not what is represented here. I'm just explaining. And then as it goes towards the periphery is called the ischemic penumbra. So the death of the tissues will eventually start from the center and start moving towards the periphery if nothing is being done. So why does that happen? Oh, well, maybe a clot from the heart will just detach and then move right way up to the brain and then occlude one of the arteries. That's the cardioembolic mechanism. And the most frequent cause in this mechanism is atrial fibrillation. When the heart beats very fast and irregularly, we're talking of the atria, there's a tendency for stasis of blood inside the atria, and a clot can easily form, and then that clot can migrate way up to the brain. For example, like what we see in this diagram here. It could be an infarction of small vessels which supply deep areas of the brain, such as the internal capsule, the thalamus, and more of that. Is going to result in what we call lacunar strokes. Lacuna comes from lake. It's going to produce very small lesions like what is seen here. And next, uncommon is low flow stroke. This one is rare, is due to hypotension. So actually in low flow stroke, we have no vascular occlusion, but due to hypotension, for example, in a shock, we've got less blood which is reaching the brain, and then we have infarcts. There are other causes, and when the cause is not identified, the stroke is said to be cryptogenic in this case. The remaining 20% is occupied by hemorrhagic strokes. So in hemorrhagic strokes, either it's the brain itself which is bleeding, that's the brain parenchyma, or we have bleeding in the subarachnoid space. So when it's the brain itself, that will be intracerebral or intraparenchymal hemorrhage. Otherwise, it is subarachnoid hemorrhage. That could be the most frequent cause is hypertension, hypertensive arteriolar rupture, for example, maybe it's an aneurysm. Vascular malformations, maybe arteriovenous malformations, arteriovenous fistula cavernomas, vasculopathies, such as here, for example, in intracerebral hemorrhage, you could have the position of amyloid in an artery, and because of that, the artery becomes brittle and it then ruptures. That is cerebral amyloid angiopathy, which is a cause of lobar hemorrhage. We're in this class. Then you could have coagulopathies as well. A tumor could be bleeding, and then we've got other causes. Well, the risk factors of cerebrovascular diseases are very much similar to the risk factors of cardiovascular diseases. We've got non-modifiable risk factors and modifiable risk factors. These are the non-modifiable risk factors: age, race and ethnicity, gender, family history. So for age, as age increases, the risk of stroke increases. Race and ethnicity, this is blacks, which are more predisposed than whites. The gender, initially men have a higher risk of stroke, but because of the fact that women live longer, they therefore have a higher lifetime risk of stroke. We're talking of about 18% against 14%. A family history maybe of a cerebral arterial disease and genetic risk factors. If we take an example of sickle cell anemia, a sickler will be more predisposed to an ischemic stroke, for example, than one who is not a sickler. Modifiable risk factors are these ones: hypertension, which is the most prevalent. Hypertension has been said to is found in about 90% of all strokes. We've got diabetes. A diabetic, someone who has been diabetic over 10 years is 3 times as likely to develop a stroke than a non-diabetic. Obesity, people who are obese or overweight have a higher risk of stroke than normal weight individuals. For example, in obesity, it's up to 64%, so that's astounding. People who have an impaired lipid profile as well. We have atrial fibrillation, a structural heart disease, maybe a valvular disease, carotid artery stenosis, and then lifestyle choices, which is really a priority focus area in community prevention. Now coming to the strategies and goals, recommendations we'll be using throughout here are recommendations of GNC8, that's the 8th Joint National Committee. I do agree that this may be, it may not be used everywhere, but it does take into account major advances in stroke prevention and the recent guidelines as well. Starting with hypertension. As earlier said, hypertension is the most important modifiable risk factor, prevention of stroke. So about 90% of all strokes, in about 90% of all strokes, we have hypertension. It has been said that 40% of all strokes can be prevented by good blood pressure control. There's a strong, continuous, independent, positive association between blood pressure and stroke, even in the normotensive range. That is, even in the range of normal BP values, apparently an increase in that range is associated with an increase in the risk of stroke. Though some studies initially suggest that ACE inhibitors, for example, and thiazide diuretics are better than others, there's really no supportive evidence of a specific class of antihypertensives. And so that is tailored really according to patient demographics and blood pressure conditions, and so is a good blood pressure. This, for example, is from the GNC8, where we see here the classes of ages and when pharmacologic treatment needs to be started or not. Secondary prevention, antihypertensives may be initiated or resumed. Patients who are already known hypertensive, or with prevention of recurrent stroke and other vascular events. All right, and that is like as early as possible, 24 hours. In this category, we should not, the threshold for pharmacologic treatment should start is about 140 on 90 millimeters of mercury. And then for lacunar strokes, lower blood pressure targets such as less than 130 are recommended. And that's because it has been proven to decrease the recurrence of strokes after lacunar strokes when this is a blood target. We'll now move on to atrial fibrillation. So atrial fibrillation, as we earlier saw, is a risk factors for embolic stroke events. And if we take into account other risk factors, atrial fibrillation will account to as high as 17% of other risk factors. What is given here for prevention of stroke in patients who have atrial fibrillation is anticoagulant therapy, and that is done with decision tools. That is because the major adverse effects of anticoagulant therapy is bleeding. So these decision tools kind of help the clinician to make the decision when should it be given, when should not be given. The most common are the CHAS-VAS score and the HAS-BLED score. So basically, this is a parameter, and to every parameter, a specific point is associated, and then the sum is being made. The classic anticoagulants which have been used over the years till now, it's heparin and warfarin. They are still being used, but due to certain limitations, such as multiple food and drug interactions, for example, need for consistent monitoring, new oral anticoagulants are being used. They're called the novel oral anticoagulants. Those are the factor 10A inhibitors and the direct thrombin inhibitors. Here, for example, this rivaroxaban, apixaban, epoxaban, and others, they are factor 10A inhibitors. This one here is a factor 2 inhibitor, dabigatran, or a direct thrombin inhibitor. So they are now being used for prevention of recurrent stroke in these patients who have non-valvular AFib. Oral anticoagulation combination with antiplatelet therapy, that is not recommended. And for patients who have had an event, what I mean by an event is a stroke or a TIA, an AFib, then aspirin is given if they are unable to take oral anticoagulants. We're talking of patients who have an event and AFib. For cryptogenic strokes, as we said, this is when the cause is not really identified. Extended cardiac monitoring for up to 30 days for AFib is reasonable. So why do they do extended cardiac monitoring? This is because they have seen that in about 30% of these patients who have this cryptogenic stroke, they actually have paroxysmal atrial fibrillation, which is kind of a form of atrial fibrillation, which is just starts and stops. We now look at antiplatelet therapy. Is given for primary and secondary atherosclerotic stroke prevention. If aspirin is initiated within 48 hours of an ischemic stroke, we have significant reduction in stroke recurrence within 2 weeks. Now, dual antiplatelet therapy is really controversial, but even when the efficacy is increased, that we have to weigh that against the risk of bleeding. This down here, for example, is an excerpt from a subgroup analysis of the CHANCE trial, which was studied here about 2 webinars ago. And this method of administration, so in that trial, they were comparing they were trying to investigate the efficacy and safety outcome of dual antiplatelet therapy with aspirin and clopidogrel versus aspirin alone in both patients who have intracranial arterial stenosis and those who do not. So what was really thrilling here was because this dual antiplatelet therapy is given for 90 days, right? It's given for 90 days, but in the first 21 days, it's just aspirin and clopidogrel before we continue with clopidogrel. That is because it has been shown that this is kind of the optimal 21 days, this first 21 days, where the efficacy of the treatment, so to speak, is better than the bleeding. So it outweighs, during this first 21 days, the efficacy outweighs the bleeding. So it may be considered as initial therapy within 24 hours or TIA or minor ischemic stroke, continue for 90 days in the way we have suggested, where this is given for 21 days and this one will continue for the remainder of the time. Then again, addition of aspirin to anticoagulant regimen has not been proven to decrease ischemic stroke as a recurrent event. Maybe it does, but it has not been proven yet. Patients with an impaired lipid profile. Now here there's a paradoxical relationship between cholesterol levels and stroke. Now, why do I say that? High cholesterols have been noted to have to be associated to an increased risk of ischemic stroke. At low cholesterol is paradoxically associated with an increased risk too, but this time of hemorrhagic stroke, and it's not really well understood why. So that's the reason we talk of a paradoxical relationship. Medical management starts with estimation of the total cardiovascular risk, and what is given is usually statins. Statins are given and for a specific target, and that target is based on a 10-year risk of atherosclerotic cardiovascular disease. This, for example, is again an excerpt from the 2019 ESC-ES guidelines, the European Society of Cardiology, European Atherosclerotic Society guidelines for the management of dyslipidemias. So what is done is that based on this score, because the final result is that they will use a score and they will use some other comorbidities. So based on this, the patient will be classified either as very high risk, moderate risk, or low risk. And then this will correspond to a specific LD target with the medication we've talked about. We talked of statins. So let's take an example. Let's say a 65-year-old male European, because this is for Europe and this is just a part of it. 65-year-old male who is a smoker. Let's take his systolic blood pressure maybe at 160, and his total cholesterol, something like it is 4, 5, 6, 7 for total cholesterol. Let's say his total cholesterol is at 6 millimoles per liter. So this he is going to be a smoker 160. So he's a very high risk patient, 24%. So this is the target for him. We give statins to obtain this less than 55 milligrams per deciliter. That's the LDL target. So if you have to base yourself on the risk alone, usually greater than or equals to 10% is very high risk, 5 to 10 is high, 1 to 5 is moderate, and less than 1 is low. For patients who cannot achieve their recommended targets, despite being given statins and other anti-cholesterol medications, there's a new class of medication. These are the PCSK9 inhibitors. The PCSK9 inhibitors. Our liver has LDL receptors which capture the circulating bad cholesterol, that's the LDL cholesterol, to be broken in the liver. So technically, the more LDL receptors we have in our liver, on our liver, the better for us, because by then we'll be capable of reducing or clearing our blood of this bad cholesterol. PCSK9, which by the way stands for proprotein convertase subtilisin casein 9, is a protein which is produced by the liver, and it actually breaks down the LDL receptors. So this protein normally decreases the number of LDL receptors on the liver. If the number of LDL receptors decrease, then we are incapable of clearing fully our blood of the bad cholesterol. The inhibitor then is given to prevent the breakdown of these LDL receptors. So since it inhibits the breakdown of these receptors, we have more LDL receptors, and hence we can clear our blood of this free bad cholesterol. That's the LDL cholesterol. In secondary prevention, high dose atorvastatin is given. We're talking of about 80 milligrams. It has been shown to reduce the risk of stroke by 43% and cardiovascular events in general by 26%. Diabetes, as we earlier said, someone who has been diabetic for over 10 years is 3 times as likely to have a stroke than someone who is not. Though there's no proven direct risk between diabetes and primary hemorrhagic stroke, aggressive diabetic control is really prudent, and the target here is this is glycated hemoglobin to be less than 6.5%. The very common and most important anti-hyperglycemic agent, metformin, has equally been shown to have potential benefits in reducing clinical atherosclerosis. The other hypoglycemic agents could be given as well, because have equally been shown to have a certain efficacy. But in a nutshell, there are existing guidelines for glycemic control for lipid and blood pressure targets in diabetic patients who have had an event, that is a stroke or a TIA. Lifestyle modifications, here is really where each and every one of us can really act, to decrease our risk of stroke. And this is a priority focus area in community prevention. A good diet to reduce our risk of stroke should contain less salt, because this will lower the BP. It should contain more fruits and vegetables, whole grains, for example, nuts, olive oil. This is what is called a Mediterranean diet. Should contain less sugar, less saturated fat, less trans fat, less red meat. So this is fatty cost of beef, pork, goat, fatty dairy products. So less of all of that. But moderate amounts of fish, poultry, and dairy products will be allowed. So that is a proper diet. You should eat much of fruits and vegetables. And here actually there's a stroke survivor. His name is Prince Query, who said that after 40 years it was really difficult for him to change his diet. So this is someone who had a stroke, And then the most difficult thing for him to do after to prevent recurrence was to change his diet. He said it was difficult, but it was a change for life. So finally he did it. Before he didn't eat any much of fruits and vegetables, and now he just eats that. He eats just that, and he's actually an advocate of eating healthy and doing exercise. In 2018, the World Health Organization declared that 1 out of every 4 adults is not active enough, and that more than 80% of the adolescent world population is insufficiently active. So what was WHO calling active? That was about 150 minutes of moderate to strenuous exercises a week. This is really pretty much the same as what GNC8 proposes, 40 minutes per day, 3 to 4 days a week. So exercise. Burning 2,000 to 3,000 calories per week decreases stroke risk by 50%. This is another amazing fact. Now, the risk of stroke, ischemic in particular here, is increased in overweight and obese individuals, as we earlier mentioned. This percentage is very high here, up to 64% in obese individuals. And again, exercise is very important to do. Alcohol. Chronic alcoholism and heavy drinking is associated with an increased risk of stroke. There somehow seems to be a protective effect where at very little doses it may decrease the risk of stroke, but the exact quantity is not really known. That's why we talk of a J-shaped association here. So at a small amount of alcohol, there seems to be a protective effect, but as we increase the doses to become a chronic alcoholic, really the risk of stroke is increased. So there's this common saying that 1 glass of wine a day keeps the doctor away, or one glass of alcohol keeps the doctor away. But the real question is, what is 1 glass? If it is beer, those who said that it was about 12 ounces of beer and about 5 ounces of red wine. 12 ounces is about 350 milliliters, or 5 ounces of red wine, and with 2 to 3 days without drinking in a week. So this is what they propose. So when they say 1 glass of wine a day or 1 glass of alcohol, one should really know the meaning of 1 glass, because if your glass is like this one here, then probably we're having strokes after every glass. So you should stop or decrease alcohol consumption. That's recommended for patients who have had an event. Those who have not had an event should really moderate alcohol consumption, or you stop if you can. Now, smoking is a leading preventable risk factor too. And for patients who have never smoked, they should abstain from smoking. And for those who are smoking, there are smoking cessations which are available, such as counseling, such as drug therapy. And passive smoking should be avoided as well. We'll now look at structural interventions in secondary prevention. These structural interventions here, they really concern about an artery such as this one, the carotid artery, which has a stenosis, so there's atherosclerosis there, and it has decreased the size of the lumen. So the two interventions which are competing against each other here are endarterectomy and stenting. So endarterectomy is opening a vessel and you remove the plaque from endo inside artery, and ectomy removing something, and the stent is a device introduced to increase the size of the lumen. So endarterectomy preferred to stenting in patients over 70 years old due to a high risk of perioperative complications with stenting. Equally preferred over stenting, patients who have symptomatic carotid stenosis resulting in a TIA or a non-disabling stroke. With this stenosis, this range 50 to 99%. And this should be done in asymptomatic patients over 70% stenosis if the perioperative risk is less than 3%. Now, stenting over endarterectomy, that will be a symptomatic patient at average or low risk of complications associated with endovascular intervention when the stenosis is respectively 70 and 50%, depending on whether it is by non-invasive imaging or by catheter-based imaging. Stenting will equally be preferred to endarterectomy in patients who are not candidates, maybe due to other comorbidities, maybe due to anatomical limitations of the surgery. So people who have severe stenosis of a major intracranial artery, 70 to 99%, dual antitherapy is recommended with aggressive 90 days again, plus 21, and then we continue with this. Dual antiplatelet therapy, aggressive LDL and blood pressure management is still better than stenting. That will still be better than stenting. Concerning the patent foramen ovale. So if you have a patent foramen ovale, a clot can easily form. It's called a paradoxical embolus because this one will instead be a venous clot, and then it's going to pass through that and then still migrate way up to the brain and then occlude an artery, and you can still have an event. So for these patients, patent foramen ovale, that it should be closed. You should have closure, and then they should be given anti-thrombotic therapy, but the closure is based on certain indications when is closure considered. For example, here, high-risk echocardiography, multi-territory infarcts, recurrent stroke despite medical management, and other predisposing risk factors. We will now consider the subject of stroke in women. So why are we talking about stroke in women? As we said, though men may seem to have an initial high risk, women live longer. Because of the fact that women live longer, they have a higher lifetime risk of stroke than men. Of those who die from stroke, 60% of them are women. Women have worse outcomes in terms of functional status and quality of life. And sadly, women are equally underrepresented in stroke prevention trials. For example, in antiplatelet trials, we have 61% men, 39% women. In carotid intervention trials, this is about the same. So that would be 31 here and instead 69 here. So it's still basically the same values. Now, looking at stroke of women, there's a very interesting paper published by Professor Bushnell about 6 years ago, which studies the subject of stroke in women. This is what she had. Women-specific risk factors of stroke. So, you see, men do not have this. Pregnancy, preeclampsia, gestational diabetes, hormonal contraception, postmenopausal hormonal use, changes in hormonal status. These are women-specific risk factors of stroke. Among factors which are present in both men and women, the risk is really still increasing in women. So these risk factors here, for example, are present in both men and women, but they are stronger or more prevalent in women. Migraine with aura, atrial fibrillation, diabetes, hypertension, depression, psychosocial stress. And then this one here, similar prevalence, lifestyle modifications, age, prior cardiovascular disease. This is still a part of lifestyle modifications and metabolic syndrome. Considering preeclampsia and gestational hypertension, for example, they double a woman's lifetime risk of stroke. So recommendations are to evaluate all women 6 months to 1 year postpartum and those past childbearing age with a history to document it as a risk factor and then evaluate and treat other cardiovascular risk factors as well. This one here is another biggie, hormonal contraception. Hormonal contraception. This, for example, this table here shows patients who will be taking contraceptive, in fact, a woman contraceptive against one who will not be taking. So, for example, for this risk factor, high cholesterol, if she's not taking, the odds ratio is 1.1, but if she's taking, it will be up to 10.8. So this is really amazing. So women should be screened for risk factors before starting hormonal contraception. And if they have other risk factors for strokes, really other contraceptive alternatives are possible. It could be an intrauterine device, something else, because hormonal contraception with risk factors of stroke is dangerous. It is dangerous. There are tools for evaluation of a stroke risk which are available online, but those tools really, they do not consider all ages. They start at from 40. Not only do they not consider all ages, but they do not consider women-specific risk factors as well. So risk scores should accommodate that so that corresponding prevention strategies can be adopted. That is for women. We've come to the end of this presentation. To conclude, we've talked about stroke primary prevention and secondary prevention. Primary prevention is addressing the risk factors. Secondary prevention addresses the risk factors too, but usually is based on the etiology. For hypertension, we give antihypertensive, and the choice of antihypertensive is tailored according to patient demographics and comorbid conditions. For atrial fibrillation, it is anticoagulants which are given together with decision tools, or decision tools to enable us to balance the benefits with the harm of the treatment, which is bleeding. We've talked about the place of novel oral anticoagulants. We've talked about antiplatelet therapy being used for both primary and secondary prevention. Patients who have an impaired lipid profile being given statins. We've talked about the new class, the PCSK9 inhibitors. We've talked about a priority focus area in community prevention, which is lifestyle modifications of a diet, a proper diet, more fruits, more vegetables, less salt, less sugar, less fat. For smoking, you should quit. For alcohol, it should be moderate. For exercise, 150 minutes of moderate to strenuous exercise a week. That is about 40 minutes, 3 to 4 times a day. 3 to 4 times, 3 to 4 days a week, I mean. So this here are 7 tips I can do to prevent a stroke. Lower blood pressure, treat atrial fibrillation, manage diabetes, lose weight, exercise more, quit smoking, and if you drink, should do it in moderation. So one of the objectives of the presentation was to contribute to community prevention. This can be done by raising awareness in our communities. For example, the World Stroke Day is on October 29. Some countries such as the US have a National Stroke Awareness Month, for example. It is May in the US. So we could raise awareness on the risk factors of stroke. And it is commonly said that for every minute spent in ischemia, about 2 million neurons die. So we could equally sensitize the population about how to recognize a stroke, because if they know that, they can really act fast. The acronym which is used is FAST, where F stands for face, so does one side of the face droop when smiling? A stands for arms, does one arm drip downwards when both arms are raised? Can he even raise the arms to begin with? S will stand for speech, is a speech slurred? And then T stands for time. Time to call the emergency number in your country, time to rush the person to the nearby health center. So we could raise awareness on the risk factors of stroke, but equally raise awareness on this, how to detect a stroke, so that then the patient can easily be rushed, or the person can easily be rushed to a nearby health center. We've come to the end of the presentation. Thank you very much.
Thank you so much, Celestin. Fantastic presentation right there. This was really well done. I encourage everyone else, all our members, to present the way you did. Your slides were clean, your material was well researched, you presented with good delivery, really, really great presentation. I would say, from what you've already given us, let's charge the communications team to work on an advocacy strategy for the stroke prevention, the stroke day, the World Stroke Day, which is October 29. Let's try and have infographics for our social media accounts, and why not even a few videos? We can have a few people record videos in local languages, so be at least French, English, and even Pidgin, or for those countries in which there's Pidgin, that we can communicate on our platforms, especially explaining FAST and the 7 tips that our friend Celestin just shared with us. Fantastic presentation, really. So my first question for you, Celestin, is: did you find the answer to your question that you asked during the journal club?
Yeah, doctor, I found an answer. The answer was that the first 21 days, the efficacy of the dual antiplatelet therapy outweighed the bleeding effect.
Fantastic. So that's very important. And this is a great presentation, because we have neurosurgeons here, or future neurosurgeons, and there's a neurosurgical treatment to stroke. But before patients get to the neurosurgical treatment of stroke, there's other things we can do. We would all be better if our patients didn't get stroke and the complications of stroke. So we need to be able to stop them, prevent them from getting to that level where they need neurosurgical treatment. So this is very important, definitely very important. Once again, fantastic presentation by you, Celestin. I'll open it up for questions. If anyone has a question, please send them in the chat so that we can have this with Celestin. Just as a reminder, communications team, please work on a strategy for October 29, so that we can have infographics and even short videos. We can have it with the medical student friends we have here. They can record those videos on their phones, and then we can try to come up with a montage that we can share on our different platforms. That would be a really great idea. Very important.